So we'll move on to the last session of today, and we have two speakers for the session, and I invite chairs for the session. Dr. Mujib Rahman, consultant rheumatologist, Dr. Mujib Center for Rheumatology, Perindalmanna, and Dr. Arun Baby, consultant rheumatologist, Valluvanad Hospital, Ottapalam, and NIMS Medcity, Trivandrum. So Dr. Changappa, who couldn't come in person for the conference, he has sent a video, a pre-edited video for this. So we'll have first a session by Dr. Vishnu S. Chandra, and then followed by the video by Dr. Changappa.
We'll begin this session by Dr. Vishnu S. Chandran, HOD, Associate Professor, Department of Rheumatology, Believers Church, Medical College, Tiruvalla.
Thank you, sir. Thank you, organizers, for giving me this opportunity. So, my topic of presentation today is B-cell antigen-specific immunotherapy, or BACIT, which is a precision-based immunotherapy, which is an upcoming therapy for most of the cancer-based cancer institutes as well as rheumatology institutes. The main learning curves here will be biology of the B cells, which is essential for the autoimmune diseases, the core principles of antigen-specific targeting, the key mechanisms, the clinical applications, regulatory B cells, and the challenges and future horizons. Why is B cell so essential in the treatment of autoimmune diseases? Because we know that the B cells, which are generating in the bone marrow, are immature and they are autoreactive in nearly 75% of the patients. These undergo clonal energy or clonal deletion at various checkpoints and reach the periphery, where they interfere with the T cells to produce autoantibodies. And here also, when the antigens are self-antigens, the B cells undergo energy and clonal deletion. So only the non-self antigens are selected by the B cells, and then they go for immune regulation. Whereas in certain situations, when the B cells, they become rogue and they produce autoantibodies, they are important in the manifestation of autoimmune diseases. So we should know the receptors, CD receptors in the B cells for targeting these cells. So as the B cells are developed in the bone marrow, they start developing the CD19 and CD20 in the immature B cells, which are about to be gone to the periphery. Once they reach the periphery, they develop and transit into the effector B cells, or they go into class switching and go into the memory B cells, or later into the plasma cells. These long-lived plasma cells, or the memory B cells, undergo class switching, and they also lose certain CD markers such as the CD19, CD20, and various other surface markers. So when we target the therapy for patients who are having autoimmune diseases, what we had till now was a broader therapy. And we know that B cell is not just an antibody producing cell. Instead, it is an immunity enhancing cell. Here it acts as an antigen presentation cell, where the antigen presentation is enhanced much more than the dendritic cells of the macrophages. It produces germinal centers and migrate into the tissues and infiltrate where they form germinal centers and proliferate the immune mechanisms. It also produces complement activation, immune complex formations, and induce tissue damage. So how it loses the tolerance? There are various mechanisms whereby the most important ones are the faulty negative selection, the increased B cell signaling through B cell stimulating receptors, and deficiency of the B cell inhibitory receptors. Also, the generation of autoreactive immunoglobulins during somatic hypermutation, and increased survival through BAFF receptors. So these receptors, when they are enhanced, the B cells loses their tolerance and undergo autoimmunity. So the core principle of antigen targeting or specific antigen targeting is that what we were using till now is the sledgehammer mechanism, where the broader B cells are, or the non-pathogenic B cells are also destroyed in the course with broader immunosuppression by anti-CD20 antibodies or the cytotoxic therapies. Here, most often these patients relapse, and once the B cell repopulate, the immune mechanism is not rebooted. So the antigen specific or the precision therapy or the surgical scalpel based therapy is very important. Here we have various mechanisms by engineering T cells or targeting the B cells and T cell mechanisms. So we know that by targeting the patients with non-specific therapy, the patient undergo a lot of cumbersome procedures. They have infections, they have infertility, chronic disability, psychosomatic problems, as well as organ damage. So to curtail this, the cell-based therapies came into action. This is taken from the or targeting the autoantibodies on the tumor cells. What we have been using till now is the anti-CD20. Why it was not so effective? Probably because of the excessive action of the activating factors or excessive use of the CD20 leading to internalization of the receptors, etc. So the cell-based therapy is more specific, and it has two strategies. The main strategy is the eliminating strategy, where the CAR or the chimeric antigen receptor modified T cells are targeted towards the CD19 B cells or the BCMA antigens on the B cells, and it eliminates the pathogenic B cells. Or dampening strategy by inducing tolerance by use of regulatory T cells or tolerogenic dendritic cells, mesenchymal cells, etc. So what are CAR T cells? These are cells which are helping in identifying an antigen, recognizing it, and expanding in our circulation, and induce a cytotoxic effect and inducing immune synergy. So the generation of the CAR Ts have come from generation 1 to generation 5, and as we know that the generation 1 was only helpful in binding because it didn't have any co-stimulatory molecule. But introduction of the CAR T co-stimulatory molecules like CD28, 41B or the CD 127, etc., increase the affinity of the B cells and increase the proliferation of the CAR T cells in the circulation, and targeting the autoreactive cells. So by introducing these co-stimulatory molecules, interleukin 2 is produced, or various other cytokines are produced. And the generation 4 and generation 5, where they have used various co-stimulatory molecules to induce cytokine production or introduce a switch on and switch off therapy, is also helpful. So how does this act? The CAR has a extracellular domain which has a single chain fragment variable, and it binds to it is a chimeric molecule which is induced by the vector induced generation of these receptors. These receptors attach to the antigen and activates the cell against the attached cell. So the most important region in this is the hinge region. The hinge region helps in reducing the spatial hindrance, and it enhances the attachment of the antigen with the proper affinity. And the transmembrane domain, which contains CD8, CD4, and the CD28, helps in enhancing the T cell maturation, T cell replication, etc. Now, how we go ahead with the treatment protocol? The main treatment protocol starts in autoimmune disease by a washout period, where the patients who are already on a immunosuppressive therapy, the therapy is withdrawn for at least 7 to 4 weeks, and which includes the reduction in the dose of corticosteroids and other therapies. And the patient's blood is then harvested, and the T cells are isolated, which contains the CD3, alpha CD3, and the CD28. They are then genetically modified by a vector, viral vector most often, and these T cells are used to replicate and expand, and they are reintroduced into the patient. Before reintroduction into the patient should be lymphodepleted with fludarabine and cyclophosphamide, which helps in increasing the T cell population inside the patient. And the quantity is about 1 to 5 into 10 raised to 6 cells per kilogram body weight. And this the use in SLE and other autoimmune disease came with the help of coexisting diseases in B-cell lymphomas and SLEs. So Basta et al. Showed that anti-CD19 CAR T cells were helpful in clearance of the pathogenic B cells, and it suppresses the antibodies, and it was superior to antibody-based therapy, which is broader and had a success in preclinical area. But the breakthrough case was when a patient with severe refractory SLE with no response to B cell therapy and a high disease activity was infused with the CD19 CAR T, and which showed immediate response with decrease in dsDNA, normalization of the complements, and reduction of the SLEDAI score. And no further adverse events and sustained remission was maintained in these patients. And dual target therapy was seen in patients who was having a diffuse large B-cell lymphoma and SLE coexisting. And the patient was targeted with BCMA CD19 dual CAR T cell, and which showed sustained remission in patient without any relapse or long-term complications. And this was extrapolated into other autoimmune diseases like systemic sclerosis and inflammatory myositis. The response what we got in SLE was that rapid depletion in the B cells, which are pathogenic, as early as 6 days, the deep tissue was depleted from the pathogenic B cells. It was superior to rituximab in the form of depleting the CD19 cells, and sustained energy was maintained. And these this mechanism helped in reduction and depletion of the autoantibodies, whereby the dsDNA completely disappeared, the anti-Smith antibody cleared, type 1 interferon signature improved, and the immune complexes also reduced. And the B cell, which repopulated as early as 60 days, the patient had a naive phenotype where the patient had a CD27 negative IgM antibody, IgM cells, and the B cells did not have any anti-pathogenic plasmablast in the patient, and long-term immune remission was attained. In systemic sclerosis, this was not the condition. The patients, around 6 patients were introduced into the treatment, but only 1 patient got response. This patient was given a 3rd generation CAR T, and this was because the patient was having diffuse myocardial fibrosis, interstitial lung disease, pulmonary hypertension, and the 3rd generation was used because of the severity of the disease and refractory nature of the disease to multiple therapies. This led to a sustained B cell depletion, sustained immunosuppression in this patient, and had initial cytokine release syndrome, and had a good improvement in the myocardial fibrosis, the lung fibrosis, as well as the overall score of the patient with of the skin. And the 3rd generation CAR T had a robust and prolonged persistence alongside exhaustion of the T cells, which are marked by the increase in PD-1, CD57, and TGIT. So far, what we know is that the B cell targeted CAR T cell therapy, which unlike oncology, treating in oncology, the patient had a rapid increase in the T cell and a rapid depletion in the T cells. And also the repopulation of B cells were faster when compared to that of hematopoietic malignancies. So the factors leading to this is probably the antigen clearance itself, or a T cell exhaustion, as we know that the patient's T cells have already been exhausted in autoimmune diseases. And differentiation into less proliferative subset is another reason, and host immune response, which depleted the CAR T itself. Now, in patient with CD19 based CAR T therapy, the depletion of B cell was as early as 6 days, repopulation was as early as 60 days, the reconstitution was complete in 112 days, and immune recovery and naive B cell dominance came into existence. This is a pure immune repertoire reset, or a reset of the immune system. And this was not associated with any relapse. But there are different types of antibody elimination in CAR T cell therapy for patients with autoimmune disease. The rapidly eliminated ones were that of the anti-dsDNA, anti-ssDNA, anti-nucleosomes. And this is probably because of the CD19 positive plasmablasts which were the reason for this. Whereas some diseases like Sjogren's syndrome or patients with scleroderma, the clearance was not so fast. There was a decrease in the antibody, but it persisted, or there was only a slow decline. This was probably because of the persistence of long-lived quiescent plasma cells in a protected niche, or lack of CD19 or low expression of CD19 on the plasmablast, which made the cells resistant to the treatment. And it is important to note that the CAR T cell therapy with the CD19 targeting had no response or protective response of the vaccines were retained, and this showed a therapeutic window where the immune reset is done without disturbing the pre-existing antibodies. Now, the safety profile of these patients had around 78% of them had cytokine release syndrome, and it was not more than grade 3. And the 93% of the patients had only mild cases, and tocilizumab was used only in 33% of the cases. This was not the case in treating B-cell lymphomas or other hematological malignancies. This is because of probably the lower target antigen burden, the lower the targeted cell depletion was more specific, and there was low autoimmune burden of the B cells. Now, when we look into the adverse event timeline, the patient who is initially during the washout period can have severe disease flare, as the patient is already in a refractory state or in risk of disease flare. Depletion of the immunotherapy itself might worsen the patient's condition. Next is the phase when we deplete the lymphocytes, and this leads to severe cytopenias, risk of opportunistic infections, and use of prophylactic antibiotics and vaccinations are mandatory prior to the therapy. And cytokine release syndrome usually peaks at the 3 to 5 days after infusion. And ICANS, which is an immune effector cell based neurotoxicity syndromes, which is rare in autoimmune disease but seen in patients. And late infections and immune reconstitution, and long-term monitoring for relapse or severe hypogammaglobulinemia is mandatory. There was one case of immune-mediated myositis which showed a relapse, and this relapse was occurred after 12 months of CAR T infusion, and the failure was probably due to the failed this was the retreatment with the CAR Ts again failed, and targeting the plasma cells with the anti-CD38 monoclonal antibodies was helpful. This shows us that the complexities of the autoimmune pathogenesis and need for a multimodal targeting in this. So we have other targets such as the BCMA, which is the B-cell maturation antigen, the anti-CD138 and the CD38. So the problem with the advantage of targeting BCMA is that the long-lived plasma cells are completely destroyed, and unlike CD19 therapies, BCMA targets terminally differentiated plasma cells. This eliminates the pathogenic B cells in toto, and here the diseases like neuromyelitis optica and diseases like Sjogren's syndrome may be helpful. The severe myopathies like anti-SRP myopathy, they may benefit with the BCMA targeting. But the concerns are that since the patient is targeted with the plasma cells, they have a long duration. They take long duration for the repopulation of the B cells. The B cells will lose their capability to protect from other disease, and the vaccine antibodies are also depleted from these patients. Then the consideration for dual targeting, that is CD19 and BCMA, like we saw in the patient with the diffuse B-cell lymphomas. But here again the concern is with profound immunosuppression, difficulty to repopulate the B-cells for a longer duration, and near total humoral reset. till now we were targeting all the B cells with either CD19 or the BCMA or CD20. Now there is an upcoming trend with use of targeted therapies to autoantigens. This includes the CAR-T, the CAART, which is the autoantigen bound or autoantigen engineered into the T cell receptors, and the catcher cells. These CAR-Ts and the catcher cells are the next generations where they have autoantigens loaded onto the either the CAR or onto the T cell receptors are modified in such a way that they have a antigenic receptor, antigen present on the receptor. So this helps in various diseases where the disease target is very specific, such as pemphigus vulgaris, myasthenia gravis, or diseases where the autoantigen or the antibody can be targeted very specifically. But in diseases which are systemic, like SLE, rheumatoid arthritis, it cannot be used because the multiple autoantibodies are produced in these patients, and targeting one will not help in killing the autoreactive B cells. And the next mechanism is by targeting the regulatory T cells. So the difference between the catchers and the CARs, I have told, the shift in the therapy from the catchers and the CARs into the T regulatory cells have come into action. Here the importance is that the catchers or the T regulatory CAR cells, they have a FOXP3 and the antigen receptor on top of the CAR-T have an autoantibody. This helps in inducing a B cell specific immunosuppression where the B cells become more tolerogenic, produce more interleukin 10, and helps in maintaining tolerance. Now, how to overcome the exhaustion of the T cells? Here we can target the PA3K pathway, whereby the T cell exhaustion can be depleted, or use of suppressive therapy and antigen escape mechanisms by using multiple targets can be used to overcome the exhaustion or resistance mechanisms. Natural killer CAR-T cells are the next horizon for autoimmune disease, because till now CAR-T cells had to be engineered from the patient's blood, and these cells can't be used off the rack. The problem with this is that the patient might go for disease relapse, the patient might face various problems like infections and other damage to the tissues itself. But natural killer CAR-Ts, these are cells which doesn't have HLA-B receptors and doesn't work in the way the T cells. So it can be produced an autologous way and can be transfected to the patient. So thereby they can produce a antigen-specific B cell therapy off the shelf and in a faster pace. And the duration of action of these NK CAR-T cells are lower than that of the CD19 or the BCMA CAR-T cells. Now, allogenic CAR-T cells itself. This is another mechanism whereby the gene editing approach is used to remove the HLA receptors, the T cell receptors, and the PD-1 knockout, thereby increasing the effectiveness of the CAR-T. And it can be used off the rack, and the patient autologous transfusions need not be given, and the therapeutic effects can be maintained for a longer duration as there is no exhaustion molecules in these T cells. And mRNA-based CAR-T cells are a safer paradigm where the patients will be given mRNA-based lipid nanoparticles which induce a genomic change and induces a CAR-T expression on the patient's T cells without a depletion phase. Now, choosing the correct target is very important here. We don't know which target will help in which patients. Like we have already seen, the BCMA target is used in patients where the immunoglobulins does not respond faster, like in SLE. And the CD19 is used in patients who are having a broader, narrower antigen receptors. Now, long-term safety concerns include the secondary malignancies, pregnancy considerations, and long-term effect on pregnancy and persistent immunosuppression. T-cell engagers are the novel therapy which can be used off the rack and can be given to the patients with autoimmune disease. It engages both the B cells and T cells, and together leads into the energy of the B cells, and it is based on a shorter half-life of this therapy, and can be given for a patient with without treating with cytotoxic drugs. So treating in RA patients with bites helped in decreasing the joint inflammation, which was shown in Doppler Doppler effect, and the B cells were targeted specifically for the autoantigens and depleted very fast when compared to that of the CD19 targeted CAR T cells. Next is the teclistamab and blinatumomab. These are the antibodies, T-cell engaging antibodies, which targets the BCMA and the CD3. This was helpful in myasthenia gravis and refractory patients who were refractory to conventional therapy. Then in patients who had already undergone stem cell transplantation, use of bites decreased the organ-specific damage. So the key challenges here are the majorly that of bystander killing. The organs which are already affected by the autoimmune cells undergo damage. The macrophage activation syndrome, T cell dysfunction, and immunosuppressive interactions. So this can be overcome by using immunosuppressive drugs like MMF and reducing the autolysis of the this one. So it is much effective in depleting the B cells and used very faster. Next is Siglex. This is the last one. Siglex are sialic acid binding immunoglobulin like lectins, which induces an inhibitory effect into the T cells, into the B cells by acting on the inhibitory pathways. That is the items. And epredosumab was the initial drug which was used, but it didn't show any effect. So various other methods whereby the autoantigens were linked to the Siglex and introduced in various methods like polymeric scaffoldings, vesicles, and tolerogenic drugs which were targeting multiple targets. And introducing a drug into the stalls also helped in reducing. So the next generation is basically obviously the CRISPR-Cas technology, the AI-driven designs, and synergistic use of multiple mechanisms like molecular as well as cellular, multi-targeted therapy, etc. helps in targeting the B cells without targeting the non-pathogenic B cells and resetting the immune system. Thank you.
Due to lack of time, we are going to the next session.
We are into the last session by talk by Dr. Chengappa. Unfortunately, he is not able to come personally, but we will have a video presentation. And hopefully, you will be able to answer the questions later. And he did his DM from JIPMER, Pondicherry, and he has the best paper oral abstract award APLAR 2024, into its credit, and over 80 publications. I think we can go ahead with.
Good afternoon, everybody. And at the outset, I would like to thank the organizers for giving me this opportunity to talk about a topic that I like dealing with, urticaria, because it is easy to deal with. Rather than a lupus, I would deal with urticaria. And it's interesting how the field is evolving. So I thought I'll share my thoughts about it and aspects of how we treat it. So when we talk about urticaria, how are we going to deal with it is in these steps. We'll start off with the introduction, dwell on some definitions, look at the classification and understand the pathophysiology behind them, look at the endotypes, phenotypes, see if the phenotypes can determine treatment. How do we diagnose these conditions? How do we assess the condition? How do we assess severity? How do we assess the burden? And finally, look at how we treat these patients and what is there in store in the future. So what is this urticaria? So most of us would have seen this plant because we are all from the Western Ghat belt. We have seen this plant. We call it Turike in Kannada. I think it's called some chorium in Malayalam. This is the plant which, if it comes in contact with your skin, will result in such a rash. This rash in English is called as nettle, or we call it as angarakaji in our language in Coorg. So this rash is extremely itchy. It's well circumscribed. It is elevated. It is superficial, and it is transient. This is exactly what urticaria is. But here, this urticaria is because of the contact urticaria with the plant. So the term urticaria actually came from the Greek word, but we derived the term urticaria from the botanical name for this plant. So it is, as we discussed, it is a simple skin-based problem, right? What it causes is some rash and probably will go off in a day. And probably our mothers will give us some, concoction from another plant and make us drink it. And if we are more scientifically bent, we will take some antihistamine and forget about it. So is it really harmless? Yes, the acute urticaria is really harmless. But when it comes to chronic urticaria, this was a study which was just published in 2025. It was based on the Trinetics database in the US, where they saw about 62,000 patients with chronic urticaria, and they found that the all-cause mortality because of urticaria, even after doing a lot of sensitivity analysis, was way higher than all other conditions which had a chronic course. Wow, this is shocking. I was kind of surprised when I read this data. But then when we dig deeper into this paper, what we find is the biggest morbidity of chronic urticaria is suicidal ideation and suicidal attempts. Means it has got a lot of burden on the mental health of people living with urticaria. And then, as rheumatology immunology specialists, why are we even discussing this topic? Because urticaria treatment needs to be treated to target. And who is best to treat to target than us, It's not even as difficult as determining the number of joints. We just have to see the number of rashes that are coming, which is so simple. So I think we are the best equipped to really treat these patients, treat them to cure or treat them to remission that we call in our rheumatoid arthritis. The same concepts hold good for treatment for urticaria. That is why we are even discussing this topic today. If you look at the burden, prevalence, incidence of urticaria, it's quite high. It's said that about 20% of people in the world will at some point have an urticaria. And out of this, about 5% will go on to develop chronic urticaria. And similar data is also there in India. And the prevalent cases in India are huge just because of the factor that we are a big country with a humongous population. That is not the story. If you see the slide C, we find that the DALI, that is the disability adjusted life years because of urticaria, is also very high in populations where the prevalence of urticaria is high, also because the socioeconomic status is low. So this causes a real concern. When there is a high DALI, that means there is loss of productivity, there's loss of comfortable living, and there's a lot of suffering that is happening, which was related in a very dark fashion in terms of mortality. But even in terms of morbidity, it seems that chronic urticaria is a big problem. So now that we have established that chronic urticaria is a big problem and it might be our problem to deal with, let us dwell on some of the definitions. So when we come to chronic urticaria, we come across these two terms, wheals or urticaria or angioedema. So what is a wheal? The definition by the global societies say that wheal or urticaria is a superficially and sharply defined swelling. It's not a confluent, it's not a, very vague margined one. It is a very sharply defined swelling, which has a swelling in the center, and surrounding the swelling, there's a lot of flare reaction or redness, and it is superficial. Beside this, the primary complaint of the patient would be itch. There will be some stinging sensation, there will be some burning sensation, but the primary complaint would be itch. And then, when we look at the duration for which it will last for about 30 minutes, but not more than 1 day. Some of them can last a little longer, but never more than 1 day. So, this is the approved or agreed definition of an urticaria. On the other hand, an angioedema is a deep edema. It affects the lower dermis, subcutis, and mucous membrane. Because of this, it's not well circumscribed mostly. Borders are not well defined. They just slope off into the normal tissue. The main complaint here is mainly tingling and burning, not so much of itch. So that is a big problem. So when it is tingling, pain, or burning, and when it is deep and swollen, we can confuse it with arthritis, especially if it is on the joints. And then it is very slow to resolve, and it may take up to 3 days for it to completely vanish. So this is a key differentiation between an urticarial lesion and an angioedema. Now that we know what these definitions are, so how do we really classify urticaria? So for all practical purposes, for all points of discussion, I'll only be dealing with urticaria. I'll touch upon angioedema where it is relevant. So same thing with our arthritis. We have a 6-week cutoff where less than 6 weeks of arthritis would be acute and more than 6 weeks would be chronic. The same thing holds good for urticaria. So it is easy for us to remember. Acute urticaria is any urticaria lasting for 6 weeks or less, and chronic is more than 6 weeks. When we look at the chronic urticaria, so chronic urticaria are mainly of two types. An urticaria can be either induced by a trigger or it can be spontaneously occurring without a trigger. So when it occurs spontaneously without a trigger, it means it is chronic spontaneous urticaria. And when it is induced by a trigger, then we call it as chronic inducible urticaria. And what are the triggers? Some of the triggers that we commonly come across. We must have seen that people scratch their body and it will cause those linear elevated rash, which is called symptomatic dermographism. Then when somebody is exposed to cold, they develop urticaria, cold urticaria. Somebody wears a bag, or somebody ties their pant belt very tight. They have swelling there after that. That is delayed pressure urticaria. Some of us go out in the sun and develop a lot of rash, and now this is solar urticaria. So whatever the external reason is, if there is an external trigger that is inducing urticaria, then we call it as chronic inducible urticaria. So this is the main definition, classification of how chronic urticaria is classified. Now, in chronic spontaneous urticaria, we try to endotype this chronic spontaneous urticaria into type 1 or type 2B. That is type 1 hypersensitivity reaction, which is like an allergic reaction, which is also called as autoallergic chronic spontaneous urticaria, and type 2B autoimmune reaction, which is an immune complex mediated hypersensitivity reaction, but which is not cytotoxic like the type 2A. So it is not cytotoxic, it is only cytopathic, which is type 2B. So it is type 2B autoimmune chronic spontaneous urticaria. So with this classification, what is the clinical context? So acute reactions, less than 6 weeks, not persistently there. What happens? What are the causes? It is usually an allergic reaction or a post-infectious phenomena, or it can be insect bite or contact related, like our chorial, when that leaf hits us or comes in contact, we develop urticaria, that one. But in chronic, when we see, Chronic is usually idiopathic, that is chronic spontaneous urticaria. Very rarely it can be because of connective tissue diseases, especially when it is urticarial vasculitis. It can be rarely seen in mastocytosis, but it is not classically urticaria, it is urticaria pigmentosa. And lot of hereditary or autoinflammatory syndromes can, including our adult onset Still's disease and systemic onset JIA, can have urticaria like lesions, which we will discuss in the future slides. Now, why do we classify this as acute and chronic, and why is it important for us to know? Because of the natural course of urticaria. You see here, a patient who has acute urticaria, within 6 days, almost 60%, 70% of these patients will become asymptomatic. Yeah. Usually it is within a day. Within a day, almost 70-80% of them become asymptomatic and they don't develop frequent urticarias. But only a fraction of them, about 5% of the people who develop acute urticaria, will eventually become chronic. So now that is the main concern, and that is the most important burden causing form of an urticaria. So usually acute urticaria will last for less than 1 week, and acute urticaria will progress to chronic in about 5 to 30% across various studies, but usually it is about 5%. And the best part is the chronic urticaria also, with each year, the chance of spontaneous remission is high. That is, at the end of first year, about 20% go into spontaneous remission. At the end of 5 years, about 50% becomes remission. And at the end of 20 years, about 75% go into remission spontaneously. But the story is, even though they go into remission, they might relapse in up to 30% of the patients. So it is clear that acute urticaria is not so important. We just manage it, find out if it is an allergic or not, and forget about it. But if it is chronic spontaneous urticaria, then we'll have to treat them and give them a better life. So what determines this chronicity? There are a lot of factors. Older age means chronic, more chronic. If there is an autoimmune disease, it is more chronic. If there is a positive autologous serum skin test or basophil activation test, then there will be basophenia, eosinopenia, food allergy if there is any inducible phenotype along with the chronic spontaneous phenotype. And very important is if somebody was used steroids, there is very sketchy evidence on this, but there is some evidence to say that if steroids were used, that also means that if it is very severe, I think, if steroids were used, then these patients are likely going to chronicity. Now, because you're all immunologists, let me deal with the pathophysiology in great detail, which no, I don't think we are ready for that. Let us only dwell on those that are important. So what is the culprit cell for causing chronic urticaria? Culprit cell is definitely the mast cell. So when there was a study which did a skin biopsy and looked at the mast cell numbers between healthy controls and people with chronic spontaneous urticaria. So the green one is a fluorescent dye for c-KIT, which is a marker of mast cell. So they found that people with chronic spontaneous urticaria have way more mast cells than compared to healthy controls. Beside this, there is a receptor called mast-related G protein receptor X on the mast cell, which is responsible for type 1 hypersensitivity reactions, like what we call as anaphylactoid reaction, where it might not be IgE mediated, but still the mast cell degranulates, and that is thought to be because of MRGPRX2 receptor. And they have seen that if MRGPRX2 receptor is high expression, or there is a gain of functional mutation, then the urticaria tends to be more chronic and also more severe. So mast cells numbers are high. So I have put this unrelated slide, unrelated cartoon, just for us to understand that there is a Fc epsilon receptor which binds the specific IgE. Then there is a MGRPRX, that is the G protein receptor, which is also stimulated by various various things. So based on how it is stimulated, the downstream pathway increases the calcium complex via BTK, and then finally it will release a lot of stored granules. And one of the most important granules is histamine. So coming back to the similar cartoon, so what we find is we have the FC epsilon receptor and we have the MGPRX2 receptor. So on FC epsilon receptor, the specific IgE comes and binds, and when the specific IgE comes and binds, it cross-links and causes a dimer, and then finally causes degranulation. So this, if it is a specific IgE that comes and binds, IgE comes and binds to the FC epsilon and then causes degranulation, this type is called a type 1 autoimmune CSU or autoallergic CSU. On the other hand, sometimes what can happen, we have a lot of IgE, but there would be some anti-IgE, which is IgG. When this anti-IgE binds to IgE, it will cause a dimer, and this dimer will come directly and bind on the FC epsilon receptor 1. So this is IgG mediated actually, but it will act via the IgE or FC epsilon receptor. So this is called the type 2B or autoimmune phenotype, because we know autoimmune is mainly IgG mediated and autoallergy is mainly IgE mediated. So another cartoon which can explain this more easily is the type 1, where the IgE against anti-TPO and IgE against IL-23 will directly act as autoallergens. Whereas in type 2B, when there is a cross-linking that is done by IgG, usually our anti-TPO can be there and a lot of other IgGs can be there, which can bind to IgE, make a dimer of IgE, and this homodimer will attach to the FC epsilon receptor, then come down and cause mast cell degranulation. Once this cross-linking happens, one of the main components is our BTK, which we all are familiar with in our B cells. So once it acts via the downstream pathway, the BTK is activated and calcium influx happens, and then there is a lot of degranulation. And once there is degranulation, all these things happen. So there is release of histamine, there is neovascularization, there is upregulation of adhesion molecules, which brings in more mast cell to the site, and finally increases the vascular permeability and increases proliferation of more mast cells. This will eventually lead to tingling, burning, itching, which is activation of sensory nerves, vasodilation and erythema, which will lead to the wheal and flare, plasma extravasation, which will also lead to wheals, and finally some neurogenic inflammation, which leads to a systemic effect in the form of depression, fatigue, lack of sleep, and so many other comorbidities. So now that we have understood the pathophysiology, what is the clinical context and how do we really diagnose these in the clinic? So if we are thinking of an autoallergic phenotype, so these patients might have some form of other allergies also, but this CSU is not because of allergy, it is an autoallergy. But these patients have a predisposition to atopy. And this here, the disease activity is not very high usually. Whereas in chronic spontaneous urticaria, type 2B, there might be other autoimmune diseases like a thyroid autoimmunity or a vitiligo, and the disease activity is very high. And these patients have a higher incidence of angioedema, and the condition has been a kind of chronic. So CSU type 1 is a little not so refractory. CSU type 2 is kind of refractory. When we look at the lab parameters, when we do a total IgE level, in the CSU type 1, it is usually high. In the type 2B, it is usually low. There might not be any autoantibodies in type 1, but rarely low titers of ANA can be positive. But in type 2B, there is a higher chance of finding more autoantibodies like anti-TPO and other ANAs. And when you see the differential count, there will be normal eosinophil and basophil count in type 1, whereas there will be eosinopenia and basopenia in type 2b, which is also a poorer prognostic factor. And when you do a functional assay, if there is a positive serum skin test or a positive basophil activation test, then it is most likely to be type 2b. Having said this, if both are positive, then there is a higher chance that it is type 2b, because sometimes ASST can be positive in type 1 also. And finally, when you see how this translates to response, type 1 will have excellent response to omalizumab and also fair response to high dose antihistamine second generation, whereas type 2b is more chronic and might need immunosuppressive treatment. Even there, it is a little tricky and they don't respond as well. But it's very easy for me to tell this as if it is black and white, but the reality it is all gray. There's a lot of overlap between autoallergic and autoimmune CSU, and it is clinically only maybe in about 30% of patients we can really differentiate what type of a CSU it is, but we have to make all attempts to kind of tell if it is autoallergic or an autoimmune kind of CSU, because our treatment goals and treatment decisions are going to vary, especially in India. So coming to the management, so I have skipped this because if there is an angioedema, we'll have to differentiate it between histaminergic angioedema and bradykinin mediated angioedema, which is not the topic of our discussion today. I'll skip this slide. But when we come to an overview of management, our management will be in 3 steps. The first is to assess, second is to act or start treatment, third is to adjust. So please don't wait to start treatment because some of the investigations are pending. And then once we start, we should frequently adjust, not just leave it or not give patient any hope. So how do we assess? So in assessment, I think most of us fear missing out a more sinister cause. So differential diagnosis. So we have to exclude the mimics. So even the guidelines say that is the most important thing. And then we have to assess for comorbidities in these patients, see if there is a special population that we are dealing with. Then we have to look at the severity, patient preference, and finally adverse effect. When it comes to comorbidities, what are the comorbidities we are looking at? We are looking at concomitant chronic inducible urticaria. Almost 40% of our chronic spontaneous urticaria patients will have a comorbid inducible phenotype also, which we have to specifically ask, because our antihistamines may not work as well in chronic inducible forms, especially in dermographism. It might not really act well, and we might have to counsel the patient or further escalate treatment. Then we have to look for mental health disorders. We saw that suicide or suicidal ideations are there in chronic urticaria. And we have to look for thyroid gland dysfunction and some autoimmune disease. So basically what tests we do when a patient of urticaria comes is we might do an anti-TPO, we'll do a IgE, and we might or might not consider doing ANA. Beyond this, I think we do a lot of complements and all, which is not really required. Let us dwell on each of this in detail. So how do we approach the differentials? So first, our question would be that is it a young onset or a very old onset urticaria? Both these should kind of raise red flags. Are there any systemic symptoms? Fever, weight loss, arthritis, all these things. Are there any systemic symptoms? What is the duration of rash? Does the rash last for more than 24 hours? And then, how are the acute phase reactants during that time? Have they done any ESR, CRP? We usually don't do it, but we can do it. And then, the last question would be, what happens when the rash goes off? Is there a scar or is it leaving ecchymosis or a petechiae-like lesion? Usually these lesions don't leave a scar like how we see in vasculitis, medium vessel vasculitis. They only leave a petechiae-like lesion or an ecchymotic kind of a lesion. That is something we have to remember. So simple, age of onset, are there any systemic symptoms or any acute phase reactants that are elevated? Are the lesions lasting for more than 24 hours or less than 24 hours? And when they vanish, are they causing any ecchymosis or scarring? Based on this, we can decide if this patient has got any urticarial vasculitis, which is our first thing that we have to rule out, or any autoinflammatory syndrome. It could be a congenital autoinflammatory syndrome like CAPS, TRAPS, or it could be an acquired autoimmune syndrome like Schnitzler syndrome, which is because of a monoclonal gammopathy, Bleach syndrome, which is because of clonal proliferation of eosinophils, or Still's disease. Yeah. Or even Wells syndrome, which can mimic it, which is an eosinophilic cellulitis. We'll deal with this. So this is the only busy slide I have, but I took some time to put together all these clinical parameters. So if you see between chronic spontaneous urticaria, urticarial vasculitis, and other autoinflammatory syndromes, which are the three most important differential diagnoses for us. If you see the lesion duration, chronic spontaneous urticaria usually will not last beyond 2 hours. Means each rash, the whole thing might really last, the whole episode might last every day, but each rash will not last more than 2 to 3 hours. So what I ask my patients to do when they are not sure is, next time you just put a mark on the rash and take a picture every 2 hours of that mark. So you will see, surprisingly, that rash goes from there and comes in another place. It keeps moving. So that rash does not last for more than 2 hours. But if it is an urticarial vasculitis, the rash will definitely last more than 24 hours. One thing we must remember is urticarial vasculitis will have concomitant urticaria also, which, so we have two kinds of rashes in these patients, where some of them will go off in 24 hours and some of them will last beyond 24 hours. When we look at autoinflammatory syndromes, we find that the rashes will last up to 6 hours to 8 hours to 10 hours. Then post-inflammatory hyperpigmentation is the hallmark of urticarial vasculitis, same with residual marks. Angioedema is only seen associated with chronic spontaneous urticaria. It will not be seen in urticarial vasculitis and autoinflammatory syndromes. Primary sensation would be itching in CSU, pain and burning in urticarial vasculitis, and not really symptomatic in autoinflammatory syndromes. And if the face is involved, it is usually chronic spontaneous urticaria or urticarial vasculitis, and characteristically most of the autoinflammatory syndromes will not involve face. So these are most of the main, some of the main differentiating points between chronic spontaneous urticaria, urticarial vasculitis, and autoinflammatory syndromes. So when we have thought of urticarial vasculitis, especially when we have more than one clinical feature, that is, wheal is there for more than 24 hours, there is residual bruising, and there are systemic symptoms, then please do a biopsy. So we have to try and do a biopsy if possible. If a biopsy is positive, that means it is showing leukocytoclastic vasculitis or fibrinoid necrosis, then we are sure. Then we go on and do the complement levels to classify if they are normocomplementemic or hypocomplementemic, and we know how to work up for a connective tissue disease. If it is not, if we are not able to do a biopsy, then we skip the biopsy step and do the CRP, ANA, and if it is positive or if the CRP is high, then we go on and do the C3, C4 and other things. And if we are able to prove hypocomplementemic urticarial vasculitis, we immunosuppress them. If not, we updose the antihistamines and give them a lot of omalizumab. Once this is done, we have to start treating the patients. So how do we treat the patients? How do we treat the patients? So for treating, we have to know if this patient has a chronic inducible phenotype. So what are the inducible phenotypes? Symptomatic dermographism. You scratch and there will be these linear rashes. Then there can be delayed pressure urticaria. That is, you put pressure for about 10-15 minutes, and then after 2 to 3 hours, that place will become swollen and itchy. Cold urticaria is easy to prove. Just keep an ice cube for about 5 minutes, and then that place will get swollen. Solar urticaria, the patient will give you a classic history that when I go out in the sun, it becomes red, face becomes red. When I come back in about 15 minutes, everything disappears. So like this, if there is an inducible phenotype, we have to try and avoid triggers try antihistamines. And if it is solar urticaria, give them sunscreen, try creating tolerance and increasing the threshold by keeping on exposing them. And omalizumab definitely acts, and immunosuppression is not a great idea for chronic inducible phenotype. But if it is chronic spontaneous urticaria, the current guideline says start with second generation antihistamines. Please don't give them the CPMs and other things, which causes a lot of drowsiness and other side effects like dryness and tremors. Give them really high dose of antihistamines as second generation. Reassess them every 2 weeks. And if they don't respond to second generation antihistamines, then you can move on to the step 2. So what are the second generation antihistamines? Levocetirizine, cetirizine, fexofenadine, loratadine, desloratadine, and now we have the bilastine. How do we choose which one to give? You can choose anything you want. Everything is as effective as the other. But what we want to see is if there is a presence of concomitant disease, like if there is diabetes, cardiovascular disease, and depression. If that is there, try to avoid some of the very sedating antihistamines. And then we have to look at hepatic or renal impairment. If it is there, then our choices are still limited. And then you have to see if the patient needs to, concentrate during the work, is planning pregnancy. If any of these are there, then the easiest choice would be bilastine or fexofenadine. So bilastine and fexofenadine, to some extent desloratadine, are extremely safe and highly effective, and you can probably play around with these. Does not cause a lot of sedation. Then the question would be, is there any role of glucocorticoids? Now, the current recommendations strongly suggest that don't use glucocorticoids because the recommendations are from the West, where omalizumab is part of their insurance cover and can be prescribed to most of the patients. But glucocorticoids are not a total waste. In this patients where about 90 patients were antihistamine resistant, about 75 of them actually responded when initiating glucocorticoids. But we are really bothered about glucocorticoids because of the side effects, and also convincing the patient for glucocorticoid for this condition is a little tricky. And if you have to use glucocorticoid, I usually use it during their acute flares, because like CSU, like our rheumatoid, will have flares and low disease activity states. So during acute flares, I try to give it for about 7 to 10 days. This is how we give 25 milligram. You start off with three days, because lower doses of glucocorticoids are not going to work. 25 milligrams, then 12.5 milligrams, then cut it and then try and stop it within 10 to 12 days. And while updosing the antihistamines, that will give the patient some kind of a relief. And then once the patient is better, we can then switch them to our next line of treatment. Some patients are prescribed topical steroids, but they are completely useless. Maybe for a delayed pressure urticaria, it might work, especially if we do a occlusive dressing. But this topical steroids for urticaria is completely useless. Next would be H2 blockers, our favorite ranitidine, where there is this Cochrane review which says that there is some benefit of giving H2 blocker along with the first generation or second generation antihistamines. But there is only some evidence, and we are not really sure. These are all anecdotal evidence, and from what I have tried, it usually does not work, does not have any add-on benefits to high doses of second generation antihistamines. So it says that we cannot really make any recommendation for or against, and it has to be decided at an individual basis. Then the commonest thing that we give is Levocet or Montelukast. So Montelukast. Role of Montelukast, if you see, there is the systematic review which said that some very few studies really favors giving Montelukast along with antihistamines. So actually the price difference is also huge. So instead we can use a better bilastine with a higher dose, and when it comes in fixed dose combination, this Montelukast comes in fixed dose combination, it is very difficult to up-titrate the antihistamines. So I find it is useless, except if there is an eosinophilic asthma that is a comorbidity in these patients. Finally, the role of omalizumab. which is actually the drug of choice in any urticaria. It could be type 1 or type 2B. Omalizumab, if possible, should be the first choice of drug. And we see that in the Asteria, in the glacial trials, everywhere, omalizumab has outperformed even antihistamines by a big margin. And what is the dose that is recommended? The dose that is recommended is 300 milligram once a month. And if you give this for at least 3 months before determining if it is working or not working, and if you think it is not working, you can updose the drug. You can also give it 600 milligram 2 weekly or 300 milligram weekly if you think it is partially responding. But I'm sure the cost is going to be the biggest confounder in such patients. So omalizumab 300 milligram once a month is the current drug of choice if somebody fails antihistamines at the highest dose. There are some biomarkers which say that omalizumab might not work if the total IgE is low, if the Fc epsilon receptor 1 is low, if the basophil activation test is positive, that is, if it is type 2B, if there is eosinopenia and basopenia, and if there is high CRP and high D dimer, then these patients might actually have delayed response to omalizumab or poorer response to omalizumab. So in these patients, we tend to go to cyclosporin. Now I have been using tacrolimus also, but it's a hit and miss. About 40% of 40 to 50% of the patients actually respond to cyclosporin and omalizumab. But the best part is it acts relatively fast. That is, cyclosporin action starts within 4 weeks, and once it acts, the maximum benefit will be seen in about 12 weeks. And if in 12 weeks, that is 3 months, if the patient does not respond, I think we should move on and should not continue giving cyclosporin or tacrolimus. Finally, once we know what is the acting, then we have to adjust. How do we adjust? We adjust by using these two scores. One is the urticaria activity score that is measured for 7 days. Here we just say the wheal score and itching score. We say if the number of wheals are high, then we score it as 3. If it is low, we score it as 0. If the itching is very high, we score it as 3. Other moderate is 2, mild is 1, and none is 0. And we take a total count every day and at the end of 1 week. And at the end of 1 week, if the score is about 6 or less, then we can say that this is as good as a low disease activity. If it is 0, then the patient is in remission. And anything else, anything above that is actually uncontrolled urticaria. Now, once we start giving patient treatment, we can ask the patient to fill up this form. That is a urticaria control test. That is a 4-point scoring over the last 7 weeks. That is how much have you suffered from physical symptoms of urticaria? How much was your quality of life affected? How often was the treatment of urticaria in the last 4 weeks not enough? And overall, how well are you feeling? So these questions, which are patient-reported outcomes, if the score is less than 12, then we know that the patient is poorly controlled. And if the score is more than 12, then we know that whatever we are giving is able to control the symptoms for the patient. So we updose the antihistamines as the first step, then try to go for omalizumab or cyclosporin based on what type of poor prognostic factors the patient has, then keep on adjusting. But what if this does not work? There are good drugs that have come up, especially BTK inhibitor trials have been successful. Dupilumab trial has been successful. Benralizumab trial is ongoing. And actually anti-c-KIT is also ongoing. So if you see the BTK inhibitor trial so this trial, which was on remibrutinib of 100 milligram BD, they found that it had excellent control as compared to the placebo, even amongst patients who fail to respond to antihistamines. And in India, we don't have remibrutinib, but we have ibrutinib and acalabrutinib. And usually the dosage is not 100 BD. We can give them 100 OD. I have not given to anybody. And the price is going to be around 9,000 to 10,000 per month. And this was the dupilumab trial, which was recently published, which is two studies actually, Cupid A and Cupid B. Cupid A was in omalizumab naive patients, had excellent response when dupilumab was given, and Cupid B was in omalizumab intolerant patient. Even there, they had very good response, even if they had failed omalizumab. So omalizumab has been approved, and the newer guidelines that are going to come out today in this year or in 26 is going to tell add dupilumab and ramibrutinib in the armamentarium of treatment of urticaria. So to summarize, definitions wise, if it is more than 6 weeks urticaria, then we call it as chronic. Always look for inducible phenotypes. Rule out the mimics, which is very easy for clinicians like us, and try to endotype these patients based on the pathophysiological basis. Believe the natural course. Tell the patient that this is going to go off on its own. Till then, we want to just control it and treat to target like we would treat any of the spondyloarthritis or rheumatoid arthritis, and continue to monitor the patients. Thank you so much.
I think because since he is not available over the phone, we'll
We'll continue
wind
with
up
the
the session.
We'll continue with the GB.